fall in love too easily. I fall in love too easily.
Con nuestro agradecimiento a la Sociedad Mexicana de Oncología y al doctor Héctor Martínez Zahir, quien es su presidente, quien es nuestro presidente de esta sociedad, por permitirnos este espacio para esta sesión sobre cáncer de ovario y los actuales horizontes de tratamiento. Será una sesión sumamente interesante la que tendremos hoy a cargo de la doctora Kathleen Moore. Para introducir a la doctora Kathleen Moore, quiero comentarles algo que ya conocemos sobre el cáncer de ovario, pero que hay que repasarlo. El cáncer de ovario, sabemos todos los oncólogos que ha sido, todos los oncólogos de este país, y lo compartimos con América Latina también y con todo el mundo, que ha sido una enfermedad muy poco reconocida, que tiene una mayor mortalidad que cáncer de mama y que incluso que cáncer de cérvix. En México, por ejemplo, tenemos el registro de 5,000 casos nuevos al año, cuya mortalidad es del 60%. Nuestra mortalidad por esta malignidad es muy parecida a la que se presenta en todo el mundo. Al cáncer de ovario no se le ha reconocido la importancia de realizar estudios de tamizaje para su diagnóstico. En la población en general, cuando las mujeres tienen la presencia de eventos de colitis por más de 12 veces al mes, por ejemplo, y tampoco se atiende con acuciosidad la evaluación y seguimiento de quistes de ovario sospechosos o complejos, considerando la edad de la mujer, si es premenopáusica o posmenopáusica, y aún más grave, no se atiende debidamente para tamizaje ni para prevención a la población de alto riesgo para cáncer de ovario, como son aquellas mujeres desde los 35 años con historia de cáncer familiar. Todo esto que acabo de comentar está bien establecido en las guías del National Cancer Comprehensive Network del año 2019. Por fortuna, la gama terapéutica que contamos hoy para nuestras pacientes es mucho mayor, tanto con quimioterapia como con agentes biológicos. Hoy podemos asegurar muchos mejores resultados y respuestas sostenidas gracias a contar con terapias de mantenimiento para nuestras pacientes. Hoy, nuestras pacientes tienen mejores posibilidades de supervivencia a más largo plazo. Y hoy es un día muy especial, ya que tenemos una profesora invitada de primerísimo nivel para hablar sobre esto. Ella, como les decía al principio, es la doctora Kathleen Moore. Ella es ginecóloga oncóloga por la Universidad de Oklahoma, con maestría en epidemiología. Actualmente es directora de ensayos clínicos en el Stephenson Cancer Center University de la misma Universidad de Oklahoma y profesora adjunta de la Sesión de Oncología Ginecológica. Es autora principal del estudio de olaparib en primera línea, el estudio que se llama Solo 1, que ahora es un estudio clásico que escucharemos con atención, además de otros estudios clínicos que ella nos explicará con terapias biológicas. Tiene más de 200 publicaciones y tiene muchos premios a la excelencia. Pertenece al Instituto Nacional de Cáncer de los Estados Unidos, al Gynecology Oncology Group y a la Sociedad de Ginecología Oncológica. Por favor, doctora Kathleen Moore, la vamos a escuchar con mucha atención. Adelante.
Well, thank you so much, Dr. Gallardo, for the kind introduction and to the Society for this invitation. I actually love this meeting. We were talking earlier during the rehearsal about how much I enjoyed visiting with many of you in Merida last year and fell in love with Mexico. And I can't wait to someday come back when I can travel again and hopefully see you in person. But this is the next best thing. And I'm certainly excited to talk about some very recent, big clinical trial results in the treatment of women with newly diagnosed ovarian cancer. And hopefully these results will translate into new drug availability for you in Mexico as well. But I'm going to start off this talk just to frame the discussion with a case. I'm not going to talk always about this case, but it kind of gets us started. And so this is one of our patients in our practice. She presented in 2017. She was 65 at the time, presented with very classic symptoms, abdominal bloating. She was short of breath. On exam, she had a clear fluid wave, had a palpable pelvic mass, and workup revealed a CA 125 level that was almost 5,000. And on her CT scan, she had very classic findings for advanced epithelial ovarian cancer with large adnexal masses, ascites, omental caking, and some carcinomatosis. Other than that, though, she actually was and is still a very healthy person and only had high blood pressure as a comorbidity. Very interesting in this case is that she knew and had known for over a decade that she carried a BRCA mutation, BRCA2, based on other family members being diagnosed, and really, I think, was in a little bit of denial, and so did not have preventative surgery and presented with this advanced disease. And I tell you that because her surgeon, because of her BRCA2 status and the association with good prognosis, really went after this surgically to try and get her to no gross residual disease despite the extent of disease at presentation, and unfortunately was unsuccessful, leaving about 2 centimeters of residual disease all along the portohepatis. But fortunately, she recovered well from surgery, went on to receive paclitaxel and carboplatin every 3 weeks, and at the end of 6 cycles had a complete response and was no evidence of disease. And so the question for her then in 2017 was, what's next, if anything? And certainly that is the question that we ask ourselves now. And so as we start talking about the shift in the importance of maintenance, it's just important to reflect on what paclitaxel and carboplatin gets us. And it really is a very effective therapy. We have to admit that in women who present with chemotherapy naive disease, use of paclitaxel and carboplatin, and particularly the carboplatin or platinum, of course, they're exquisitely chemosensitive. And the expectation is, even in these women with very advanced disease, that they will respond, and they'll respond incredibly well most of the time with some combination of surgery. And so we know that. But what we also know is reflected in this progression-free survival curve. And I'm using this just as an example. This is ICON 8, which is published now, and its overall survival was updated at ESMO. And I don't really want to talk about ICON 8 as a study, other than to say it's probably the last non-maintenance containing trial. So it's our most recently completed trial of only chemotherapy. So it's in a modern era. So I like it for that reason. And this is the shape of the progression-free survival curve that you get when you treat a woman with advanced ovarian cancer with paclitaxel and carboplatin alone. And if you look at I don't know if you can see my arrow, if you look at the upper right-hand side of this, you see this shouldering. So this is the 20% of women who are primary platinum resistant, and we all know that portends a very poor prognosis. And we've seen this shoulder for decades. This has not changed. And the other thing to note is by about 3 years, 80% of women will have recurred. And once recurred, we have many, many therapies, fortunately. And so we can prolong overall survival and create long-term survivors, but they're not disease-free survivors. They're on chemotherapy and they have disease, and that takes a toll. And ultimately, this is a terminal illness for our patients. And so this is just a reflection of one patient's experience with epithelial ovarian cancer. So again, if you start on the left-hand side of the screen, just like my patient, she presented with a very elevated CA-125 that normalized with a combination of paclitaxel, carboplatin, and surgery. And she went quite a while. She went over 2 years before she recurred. And this patient recurred with symptoms and a little bit of a bump in CA-125, or it could just be a CT scan. There's many ways patients recur, but if they recur and they're platinum sensitive, you're going to reuse a platinum. Here we used carboplatin and pegylated liposomal doxorubicin, followed by a PARP inhibitor, and that got us a good bit of time, but it's harder to get a complete response. And so you have residual disease, which can lend itself to some side effects or symptoms. And you don't, with each kind of successive line of therapy, the time period and the benefit of each successive therapy gets shorter. The likelihood of getting a patient into complete clinical response is less, really uncommon after third and fourth line. There are exceptions, but really uncommon. So with each line of therapy, patients are entering with more disease, more residual toxicity, until such time, usually, that there's so much intra-abdominal disease that they can no longer And so we've had some moderate successes here before PARP inhibitors. And so bevacizumab, in my opinion, is a success. This is actually a very good drug for women with ovarian cancer, no matter where you use it. If you use it in the front line, if you use it in platinum, if you use it as resistant with chemotherapy, even has monotherapy activity. It's an active drug. But in the front line, it's sort of where we all have our preferences. And these are the two studies that into approval in many parts of the globe. And they're very similar studies, Jude 18 and Icon 7. They're not exactly the same, but they're similar, and the results are similar. And the thing I like to emphasize about this is I think that there's a lot of emphasis on median progression-free survivals. Like, what's the progression-free survival at that 50% mark? And so I'll hear investigators all the time saying, well, it's only a 4-month or 6-month improvement in the median progression-free survival, and that's not enough, so I'm not going to use it. But I just want to remind you all that we should think about, these are Kaplan-Meier curves, which are time to event endpoints. And so they're evaluated by a hazard ratio. And the hazard ratio is a measure of the risk, a reduction in risk of whatever your endpoint is, here progression or death, in the experimental arm versus the control arm. So if you look at 218 and Icon 7, those hazard ratios were 0.7 to 0.8. And so a 20 to 30% reduction in the risk of progression or death at every point along the curve that you use bevacizumab with and to follow chemotherapy. And so you kind of have to say to yourself, is 30% reduction meaningful to you or not? We don't see an overall survival advantage. That is true. But this is an active asset and should be considered when appropriate. So I like to remind folks that this is out there and it is a good drug. Now, when we talk about the morphology of the curve or the shape of the curve, we looked at Icon 8 and that shouldering. You still see that in both of these curves. It flattens a little bit, but you still see this drop off. Here's 6 months for 218, and you still see this drop off. It's not quite 20% until you get about 8 months. But you still see that shouldering. And here the x-axis is a little longer. Here's your 6-month mark. So you hit that about 9 months. So it pushes it out a little bit, but you still get that drop off too early of women recurring with disease, even with bevacizumab, which I think is a good drug. So we really had two options for many years. You could use bevacizumab, or you got through chemo and you did close follow-up and kept an eye on patients very closely. Those were your two options until Solo 1. So Solo 1, to remind you, was designed in 2013. Actually, 2012 was the design. It launched in 2013. So it really is an old study. It just took a long time to result. But it enrolled women with BRCA-associated epithelial ovarian cancer, advanced stage, who had a complete or partial response to combination platinum-based chemo and surgery, and were of good performance status. And it randomized them to receive olaparib, 2-to-1 randomization, olaparib versus placebo until progression or toxicity, or if neither of those happened, it stopped the assigned therapy at 2 years. And the primary endpoint was progression-free survival, and there were a number of secondary endpoints. We have not reached overall survival yet. And so I'm going to show you the updated progression-free survival curve from ESMO. When we originally presented this data at ESMO in 2018, we had 41 months of follow-up. We presented at ESMO this year with 60 months of follow-up. So this is a really nice update to show. When we presented previously, we reported a hazard ratio of 0.3, so a 70% reduction in the hazard of risk, the risk of progression or death, so an unprecedented improvement over placebo. And the medians, generally to talk about, but I know you want to hear, was not reached versus 13.8 months from the end of chemo. And so the other thing we liked to talk about was the landmark analyses at each year that patients remained on therapy. So at 3 years, we could report that 60% of women randomized to olaparib were disease-free as compared to only 27% of women randomized to placebo. So now at 60 months of follow-up, we have 48% of women still disease-free. So almost half of the women on olaparib on SOLO-1 remain disease-free at 5 years versus only 21% of women randomized to placebo. And we do have an updated approximation of the medians, which is about 56 months versus 14 months. So again, an unprecedented improvement in progression-free survival. And notably, I think I have another slide on this, but just to say, no increase in the risk of leukemia or myelodysplastic syndrome over what was reported in 2018, so 1.2%. Also very reassuring. We did all sorts of exploratory analyses from SOLO-1. This is one just looking at the magnitude of benefit in patients who had primary cytoreduction versus neoadjuvant chemo and interval cytoreduction. And the point here is that timing of surgery is prognostic, absolutely. And we unfortunately can't level the playing field with olaparib. You can't turn somebody that got neoadjuvant chemotherapy into someone that looks like they got primary cytoreduction, because they're completely different prognostic groups. However, olaparib performs the same in each of those groups. So this isn't an intervention that works better in high-risk patients or low-risk patients. The magnitude of the benefit of olaparib in BRCA-associated cancers is the same, regardless of whether you have somebody that had a primary cytoreduction or received neoadjuvant chemotherapy. The other interesting analysis that we did that's just fun to look at is the difference in benefit with BRCA1 versus BRCA2. I will remind you that only 20% of the women enrolled on SOLO-1 were BRCA2. So it's a very small number of patients, but they really do well. It's quite striking. The control arms in both groups look about the same. BRCA2 is a little better, so it's a little better prognostic marker, but they're pretty close. But the olaparib arm looks significantly better in BRCA2. There's actually mechanistic reasons why that may be true. It doesn't really change what we do or how we think about patients. We're both going to use a PARP inhibitor regardless of BRCA1 or BRCA2. I guess I just feel a little happier when I know someone has a BRCA2 because I'm hopeful they're going to do really, really well. So it's just one of those fun facts, I think, to know about the impact of olaparib in these two groups. Now, I love to show this slide, and I don't hear this as much anymore, but when SOLO-1 was first presented, you heard this a lot from very experienced investigators that women with BRCA-associated ovarian cancer were cured with chemo alone. They were such good prognostic patients that they did not need this maintenance, and we were over-treating them. And so this slide should put that statement to bed forever. So this is the group of patients in SOLO-1. It's 44% of SOLO-1 who had stage 3 disease, had a primary surgery, had no gross residual disease after their surgery, and of course they all have a BRCA mutation. So it is the best prognostic group, short of being stage 1, the best prognostic group of advanced ovarian cancer patients you will ever study. We'll never study them again. And even here, if you look at the group of women who received placebo, every one of those vertical drop-offs is a patient who is recurring. And so these are still very high-risk patients. We can probably say about 41 months, because this is from the original analysis. So at 41 months, only 20% of women in this amazing, great prognostic group remain disease-free. So they are still incredibly high risk. So the point is that there's no low-risk advanced ovarian cancer. These women are all high risk, and they deserve to be considered for a PARP inhibitor, because the magnitude of benefit here, you want your patients on the purple curve. That's where I want my patients. There is no kind of magic group that really doesn't need maintenance. Now, admittedly, maybe these 20% here are never going to recur, and they are cured. We do know that 10 to 15% of women never recur. The problem is we can't identify who they are from everybody else. So we probably are over-treating 10 to 15% in order to get benefit for the other 85%. I'm okay with that. So that's SOLO 1. And that led to very quick approval in the US in January of 18, pardon me. And then very rapidly global approvals and availability of this drug. It's still happening, but it's been a fairly rapid uptake, which is appropriate. But then the question is, okay, this is just BRCA-associated cancers, and that, if you count the somatic, that's about 20 to 25% of epithelial high-grade serous or high-grade endometrioid cancers. But what about everyone else? Will they benefit from a PARP? So here you have PRIMA. So PRIMA was presented in 2019. It's a similar study. It took patients who had responded to platinum-based chemotherapy plus or minus surgery. It could be anyone, though, not just BRCA, high-grade endometrioid, high-grade serous, and randomized them to niraparib or placebo until toxicity or progression, and if that didn't occur, 3 years. So this went out to 3 years. Now the difference here is they stratified by homologous recombination deficiency, or HRD, as measured by the Myriad assay with a score of 42 or greater, identifying those women who were homologous recombination deficient. In other words, their tumors had difficulty repairing double-strand breaks. And then any patient with a BRCA-associated cancer was included in that HRD group, and they should have tested to be HRD anyway. So it was HRD or BRCA, that was the stratification factor. And the primary endpoint was progression-free survival in the HRD group and intention to treat. And then there were a number of subset analyses. Now, the thing to know about PRIMA, because we like to compare studies to one another, but PRIMA is an outlier in terms of the population that they chose. And so I just highlighted the differences. I showed you in SOLO 1 that 44% of patients were stage 3, had primary cytoreduction, no gross residual, very good prognosis, almost half the population. Here, it's like the opposite. So 35% of patients had stage 4 disease. Almost 70% of patients on PRIMA received neoadjuvant chemotherapy. So already a very, very high risk group of patients. And 31% of patients completed chemotherapy with a partial response, not a complete response. And about half had HRD positive tumors by the Myriad assay. So this is a very different population than either the two studies, SOLO 1 or PAOLA, that we're going to talk about. But here are the results. So here's the overall population with a hazard ratio of 0.62. So almost a 40% reduction in the risk of progression or death with use of niraparib following chemotherapy. So it's an incredibly clinically and statistically important improvement in progression-free survival. But then also in the homologous recombination deficient group, that's even a greater benefit, as expected. this does include those women with BRCA-associated cancers, hazard ratio 0.43. So almost a 60% reduction in the risk of progression or death with use of niraparib. So very, very positive, very clinically significant improvement. Those are the primary endpoints. Now, these exploratory endpoints are interesting. If you start on the left-hand side, this is the BRCA-associated cancers, hazard ratio is 0.4, so a 60% reduction in the risk of progression or death. So again, in a very high-risk population, very positive finding. This group in the middle is very interesting to me. So these are the BRCA wild type, but HRD positive. So it's like 20%. If you look at all the patients who are homologous recombination deficient, 20% of them fall into this group that's BRCA wild type HRD. And here the hazard ratio is 0.5, 50% reduction in the risk of progression or death. Really significant improvement. But what was surprising a little is this group of patients who were classified as homologous recombination proficient by the Myriad assay, which I remind you is a cut point, a single cut point, yes or no, when you're measuring things on a continuum. So it's not surprising that we probably miss the mark sometimes. But here you see a hazard ratio of 0.68. So a 32% reduction in the risk of progression or death with use of niraparib in a group of patients that we now recognize homologous recombination proficient fall into a very poor prognostic group. So even amongst this kind of high risk group, this HRP group is even a worse prognostic group. And you do see this statistically significant, it's an exploratory analysis, improvement in progression-free survival. And I think the clinical equipoise question is it clinically significant? But it was significant enough that the FDA in the US and now the CHMP in the UK have approved this regardless of the biomarker. And so any woman with advanced ovarian cancer who has a response to chemotherapy can access niraparib regardless of if they have BRCA or HRD or anything. You can just use it based on PRIMA. And so that's approved now. And so we go back to our case, which is my BRCA2 positive patient. She received standard of care, was NED. We now have 2 approvals, at least in the United States and increasing in other parts of the globe, for monotherapy switch maintenance with olaparib or niraparib. And either one of these would be an appropriate next step for this patient. I truthfully, I think that they're both really good drugs and you should use the one that you're most comfortable using, and they probably have very similar efficacy. So PARP is the right answer here. Use the one you're most comfortable with. Either one is appropriate. But the reality is for this patient, remember I told you she had suboptimal cytoreduction. I would have started her on bevacizumab in my practice. In fact, that's what she got. So she would have gotten chemotherapy plus bevacizumab. I would have started that because I think it works better in that patient population. And the problem I would have had is that I would have wanted to give her a PARP, which would have meant I would have had to stop the bevacizumab in order to do that because there was no indication to get it paid for to continue the bevacizumab and start the PARP, which is really what she needs. And so that happened right after SOLO-1. You had providers either stopping the bevacizumab, or that makes people so uncomfortable to stop a drug before you've even used it to its best effect that they wouldn't use the PARP and they would keep them on bevacizumab, which is the wrong answer. And so this is sort of the conundrum that came up. And this is really where Paula came in. So why Paula was designed. So this is Paula 1. It was run in Europe, where in many countries, frontline bevacizumab is the only place where you use bevacizumab. And in fact, it's the standard of care. It's very hard to run a study without bevacizumab because it's so entrenched as standard of care. And so it's very similar to PRIMA and SOLO. It took women with advanced high-grade serous or high-grade endometrioid cancer who got chemotherapy plus bevacizumab and were in a complete or partial response following, and randomized them to continue bevacizumab with a placebo or continue bevacizumab with olaparib, again, to 2 years. And the primary endpoint was progression-free survival in the entire population, intention to treat. It was stratified by BRCA status. And so here's the primary endpoint, which was intention to treat, which is a hazard ratio of 0.59, so 40% reduction in the risk of progression or death with addition of olaparib to bevacizumab. So remember, in PAOLA, your control arm isn't placebo. It's bevacizumab, which is an active drug. And so the fact that you're showing these very impressive hazard ratios is really hard because you're actually going up against an active drug, not nothing. It's hard to show benefit against an active drug. So a hazard ratio of 0.59 is not too shabby. If you look at it by BRCA-associated cancers versus not, you have a hazard ratio of 0.31 versus a hazard ratio of 0.71. But what people really focus on are these same subgroups as I showed you for PRIMA, the BRCA-associated on the left with a hazard ratio of 0.33, in the middle, BRCA wild type, but HRD positive, hazard ratio of 0.43, again, versus an active drug. But unlike PRIMA, in the homologous recombination proficient group, there was no benefit to adding olaparib to bevacizumab. They completely overlap. Now, these are non-hypothesis tested endpoints. They're all exploratory, but there's not even a single signal in that HRP group. And so that was interesting, but very profound improvement in the BRCA and the HRD subgroups. Now at ESMO, they did update secondary analysis, which is, or secondary endpoint, which is progression-free survival 2 in all of these subgroups. And so you did see continuation of that benefit in the BRCA and the HRD groups in the left and in the middle. And then as expected, there wasn't a benefit in the homologous recombination proficient, so it remains completely overlapping. The other thing they updated at ESMO, just again, is sort of an interesting thing to know, is the response rates. So for women who came on to PAOLA with disease that was measurable, how often did they respond to the combination versus bevacizumab alone? And so not surprisingly, if you look again, starting on the left, at women who have BRCA-associated cancers, the response rate was for olaparib bev was 64% versus 42% for bevacizumab alone, which isn't too bad. Very small numbers though, just keep that in mind. For the in the very middle, for the BRCA wild type but HRD, it was 32 versus 21%. So you did see a little bit more of a continuation of response, really in all subgroups, except for the homologous recombination proficient, with the addition of olaparib, just kind of showing the continued benefit. And I think it makes people more comfortable to take someone who's gotten 6 or 8 cycles and has gotten a pretty good response, but still has some residual disease. I think this data might make people more comfortable to go ahead and transition them to maintenance with a PARP plus or minus bevacizumab, because they're going to continue to respond, and you can have some percentages that give you an estimate of how much they're going to respond. And so based on PAOLA, same approval, FDA, and then the CHMP is the only international kind of readout we have yet for either of these 2 studies, but they approved this PAOLA regimen only in HRD positive tumors. So of course, BRCA is included in that, and then BRCA wild type HRD. So the homologous recombination proficient group is excluded from getting combination bevacizumab and olaparib. They can get niraparib, but they can't get this combination by current indications. And so those are the 3 kind of big studies. And so there's a few questions we have now. So the first is, I showed you my patient, BRCA2. So is PAOLA the best regimen for BRCA-associated cancer? Is that it? You need to get everyone on the combination. And so the answer to that is that we don't know, because there's a missing arm in PAOLA. The missing arm is olaparib alone. So one thing you can't say is you can't look at SOLO, which I have here on the left, and PAOLA, which I have on the right, with very similar hazard ratios, 0.3 and 0.33, and say, well, the hazard ratios are real similar, so you don't need the bevacizumab. You just need the PARP. You can't say that at all. Remember, the definition of a hazard ratio is that it tells you the reduction, hopefully, reduction in risk of whatever the endpoint is, here progression-free survival, for your experimental arm versus your control in that population. So all you can say is that the experimental arm versus control in the Solo 1 population and the Paula population, the PARP-containing arms had an unprecedented improvement versus the control arm, which was placebo versus Bev. And so they're very positive studies, but you can't compare the hazard ratios to one another and make any kind of value judgment. Lots of people like to do that, but try hard not to. So how do you know what to do then? Well, again, the answer is we don't really know. We tried to calculate it though. So this is an interesting mathematical experiment where, because Paula and Solo were both AstraZeneca studies, we had all the individual patient data for both studies. And so we could take the women who were enrolled on Paula, who had BRCA-associated cancers and got bevacizumab and olaparib. And then we could match them with patients from Solo 1 who got olaparib. So basically we tried to pull the patients out of Solo 1 who were Paula-like. And so we did this thing called propensity-weighted matching, so that we created a Paula 1-like population out of some Solo 1 patients to create that missing arm. So we could compare bevacizumab plus olaparib, which is what you see in green on the survival curve on the right, to olaparib alone, which is the pink curve. And the hazard ratio here is 0.71, so about a 30% reduction in the risk of progression or death if you add bevacizumab to olaparib by this modeling. And so this looks additive to us. And so it is a little better. It's not as synergistic as maybe we had hoped. But what it allows you to do is, if it allows you to dissociate the decision about bevacizumab from PARP. If you want to use bevacizumab, like in my patient, she's suboptimal, or someone that's stage 4 or has a lot of ascites, I want to use bevacizumab in them. And most of the time, I'm going to make that decision long before I know their BRCA status. I'm going to have already made the decision for bevacizumab, and I'm going to have that rolling. And then I'm going to figure out that they have BRCA. This allows me to layer on the PARP and get an indication for that and an estimate of benefit and safety, and counsel my patient appropriately. And it allows me to not have to stop the bevacizumab. And I like that, actually. But if I'm not going to use bevacizumab for my patient, because I don't think it's indicated, then use of monotherapy PARP is just fine. It's just fine, because this looks additive. And so really, I think the best thing about this is that it allows you to separate the decisions, which is appropriate, because they're in no way related to one another. Use Bev if you think is appropriate, add on the PARP, or don't use Bev and then use a PARP later. It makes it very easy, I think. So this is a nice little analysis. Now, the tougher group is this group of homologous recombination deficient tumors who are BRCA wild type. And I put the VELIA data here just so you could see it for comparison, but unfortunately that study is not being submitted to the FDA for regulatory approval, so we're not going to talk about it, the study, today, in the interest of time. And so HRD positive, you have two options, just like BRCA. You can use monotherapy PARP. Here your only option is niraparib. Or you can use the combination of bevacizumab and a PARP with olaparib. And honestly, we can't do the same analysis like I just showed you because, number one, Prima is GSK and Paula is olaparib, so we don't have individual patient data from the two studies. But number two, Prima is such a different population, just globally, than Paula or Solo, that it would be almost impossible to do any kind of meaningful comparison. They're just very different studies. So we can't do that. So you have these two indications. And I think right now, based on the data, you have to think about it in the same way, or at least I do, that I think about BRCA. I just dissociate the decision. I start bevacizumab, and now I'm sending, I need to know their HRD status. So I'm sending that test. And if they're HRD positive, I'm going to add on PARP. And if they're HRD, if they're HR proficient, which we'll talk about in a minute, you have two decisions too. You can just continue the bevacizumab, or you can do monotherapy PARP, and we'll come to that in a moment. But I think you can think about this in the same way, but you've got to know your HRD status. Now, I'm really interested in this group, I will tell you, because if you recall, the studies that like Joyce Liu has done, with cediranib and olaparib, and that Dr. Mansour Mirza has done with niraparib and bevacizumab in the platinum-sensitive recurrent space. They separated out those patients with BRCA-associated cancers and those were BRCA wild type. And in both studies, it's very similar. In the BRCA-associated cancers, there's a little bump, kind of like we saw in what I showed you, a little additive bump with the combination, but overall they do great with monotherapy PARP. But in the BRCA wild type is where you saw the synergy in both of those studies. You saw this synergy that, we think that the use of these anti-angiogenic agents induces hypoxia, which downregulates a lot of your DNA damage response pathway proteins and makes you BRCA-like, so you'll respond to the PARP. And so that's where you saw the really big differences was in the BRCA wild type, in the synergy. And so I'm wondering to myself if there is more synergy with the combination in this BRCA wild type but HRD population, which we can't prove. So I'm completely just speculating. But I would like to run that trial because I would like to know if monotherapy is just as good as Bev plus PARP, or if there really is some synergy here in this combination. Because if that were true, I might not dissociate my decision about bevacizumab and PARP. If I knew there were synergy, once I knew someone was homologous recombination deficient, I'd probably add some Bev in to the end of their chemo so I could keep it going after. That might change how I behave. We don't have that data yet, but it's something I think about. So maybe we'll design that trial. And then finally, this sort of idea of do you need the biomarker at all? Because you do have the PRIMA data saying you can just use PARP, and that's fine. Many parts of the world do not have access to an HRD test. And so you have to make a decision based on BRCA alone, or if you can't even do that, you have the option to use a PARP and high-grade serous and high-grade endometrioid, and you can kind of base that somewhat on responses to chemo. Because if someone responds really well, they likely have some element of homologous recombination proficiency, although that's not guaranteed. So there's many parts of the globe where all these biomarkers are not available now, nor will they be for a long time. And so you have to make the best decisions for your patients based on kind of the information that you know. You do have an indication that allows use of PARP irrespective of a biomarker. And I think that that's potentially good for patients. It allows improved access to an important drug. And so I mentioned this group of patients who have homologous recombination proficient tumors as defined by this myriad test, which isn't perfect, but if you look across these three survival curves, we've now that we are testing, at least in the US, we're identifying women with these tumors whose prognosis is very poor. I almost don't want to know it when I find that out during the middle of chemo now. When I find out someone's homologous recombination proficient, it just makes me so anxious because I feel like I know that they're not going to do as well. And so this is a group of patients that really deserves a lot of our attention and very good trials because clearly they need help. And we do not have a best practice for them, in my opinion. I started to say earlier, if I had started bevacizumab and I found out someone was homologous recombination proficient, my practice would be to keep the bevacizumab rolling. I like the Paula control arm here. I would keep the bevacizumab rolling. But my very smart partners, some of them would say, that's one option, but this may be the only option she ever has to access a PARP inhibitor on label is now. And you may deny her that if you don't use it now. So I'm going to use a PARP in the front line instead, because that's the position where it's going to be most beneficial. And both of us or neither of us could be correct. This is just an area of complete clinical equipoise, and we really need to define what the best practice is. And it may not be either of these agents. Like we may need new targeted agents here to really help them do better. Now, we really hoped that immunotherapy would help in this patient population. That was one of our wish lists with these immunotherapy trials, that maybe we would see a signal now that we knew about homologous recombination proficiency. Maybe we would see a signal that immunotherapy worked really well for them, and that would be their salvage or their rescue. And unfortunately, I can tell you that is not going to be the case. So this was Imagine 50 that I think you've all seen. We presented it at ESMO that added atezolizumab to bevacizumab. So there's no PARP here, but clearly no clinically, unfortunately, no clinically relevant improvement in progression-free survival in either the intention to treat nor the PD-L1 positive, pre-specified, and fully powered subgroup. Really a 2.3 improvement, 2.3 month non-significant improvement in progression-free survival. We did see that the stage 3 patients did seem to do better with atezolizumab than stage 4, which goes along with the hypothesis that immunotherapy may work better in those patients who have less disease, less bulky disease. But this is, you're not adjusted for other important covariates, but it is something to think about. And in terms of biomarkers, you know, for this particular study, we used the SP142 PD-L1 immunohistochemistry, which stains both immune cells and tumor cells. And the definition of positive was immune cells greater than or equal to 1%. But we did this pre-planned exploratory analysis to look at different levels of immune cells as well as tumor cells, and did find this group of patients whose immune cells were greater than 5%, and they had a hazard ratio of 0.64, and that's their survival curve down here. So it looks a little bit better. It's not overwhelmingly positive. And so the question is this even still the right biomarker? And is this the group of patients that we can help? We have done these subset analyses to figure out if this group of patients with immune cells greater than 5%, are they all the homologous recombination proficient tumors? We're going to present that hopefully at the Society of Gynecologic Oncology in the spring, that breakdown. I'll just tell you high level, the answer to that question is no, but more to come. That data will be presented, but it's not going to be the rescue for this group. So we're really going to have to go back and look hard for other strategies for homologous recombination proficient. This is just a summary of the 3 studies that we talked about, the medians and the hazard ratios, and you're welcome to these slides. Although I see there's a little bit of an overlap, but I think you can see it's just nice. Try not to compare them to one another because they're different populations, but it's nice just to see them in one slide. I also like to just talk about testing. I think with SOLO-1, it really brought the need of testing to the forefront, and how we test and how we're cost effective with that globally is a big issue, and it still is a big issue. So this idea of testing the tumor first instead of doing germline first, so you can hopefully catch all those patients that do have a germline mutation, because it's going to show up in their tumor, and just refer those patients for germline testing, so then you can protect their families, and not test every single patient for germline. That is a more cost-effective strategy that has been demonstrated. We do miss a few germline patients, though, whose tumors will not show up in the somatic test, those with big rearrangements, for example. So it's about a 4 to 5% miss rate. But overall, if we're talking about health equity, testing tumor first may really get you a bigger impact on a kind of national scale. This is what they're doing in Canada, because they have so many rural communities that don't have access to germline testing. So they're just sending all the tumor in and getting a very rapid turnaround and reflex testing those who are positive for germline. We'll see how that plays out over time, but that is their strategy. And I think it's really an interesting one. So I'm fascinated to see how that works. And then really this just kind of, I think, gets to what you all know, that approval of PARP inhibitors really, even though PRIMA lets us use it in anyone, regardless of biomarker, that's good, but it doesn't negate the necessity for testing, because it really does help inform. If we know someone has a BRCA-associated cancer, we may be stronger in our recommendations for a PARP. I certainly am. But also we know that we can cascade test family members and try and prevent, my patient that presented, she should have had her tubes and ovaries out decades earlier, and she just was in denial, and I think no one was talking to her about it. So she was just allowed to go through life. But really, if we're aggressive, we can prevent these tumors and create previvors. And that's the goal, kind of put ourselves out of business here. So the testing remains incredibly important, not just for identifying women who will benefit most from PARP, but also families that we can help prevent this breast, prostate, pancreas, ovary, all the things that we may be able to prevent, dread diseases, if we know their genetic risk. So incredibly important. And with that, I thank you for your attention. This is my dog Yoda, who's currently asleep right there. Thankfully, he did not bark this whole time, so he'll get a treat later. And I'm happy to take questions. Right on time.
Muchas gracias, doctora Kathleen Moore. Adelante.
We're gonna do some questions now, and some of these have more than one right answer, but I'm just gonna read them to you. So this is just to see what you're doing in Mexico. So how are you currently deciding how you're gonna test women with epithelial ovarian cancer for their risk? Are you testing patients just for BRCA1 or 2? Oops, I don't know if we have enough time. That went a little bit fast. But really the question was just to get at if you're testing just for BRCA1 and 2 germline, whether or not you have access to panel tests. So you can do BRCA, RAD51, BRCA1, PALB2, germline, or are you doing tumor testing first and then reflexing? Are you kind of being Canadian in that way? Or are you unsure? So just trying to see what you're thinking. So it looked like most people were just doing BRCA1 and 2, which is fine, but that's interesting. We'll see how things evolve in Mexico as more tests become available. So this is just a question about bevacizumab use in your practice in Mexico. Do you use bevacizumab in everybody? Is it allowed? Do you never use bevacizumab? Do you use bevacizumab only in patients who have high-risk features, like we mentioned, ascites, stage 4, suboptimal disease, or you don't really know kind of when you might use bevacizumab? So a lot of high-risk use. I think that's very similar to the US. You know, there's not a great deal of use it in everybody, but people who believe in it will use it in kind of high-risk patients. This is just a patient, so, you know, regulatory and cost aside, if you could use whatever you wanted, and patient presents to you with stage 4 epithelial ovarian cancer, you're going to give her neoadjuvant chemotherapy because she's stage 4, she's BRCA wild type. How are you going to plan her therapy? What are you thinking of in terms of these 3 options? You can use platinum chemo with Bev and Bev maintenance, platinum chemo with Bev, Bev and olaparib, or platinum followed by a PARP, or other. So kind of 30, 30, 30, yeah. Well, nope, Paola's coming up. Yeah. I have to say I like the Paola regimen as well. I'm kind of a more is more person, hence my name. And then the last question is, again, current indication and cost aside, assuming you can get whatever you want to use, is there a patient for whom you wouldn't use a PARP inhibitor? So these are just sort of statements. You know, you either think PARPs are indicated in all patients who achieve a complete or partial response to frontline therapy. Number 2 is PARPs are indicated only for patients with BRCA-associated cancers who achieve a complete or partial response, or only indicated for women with HRD inclusive of BRCA. So do you think there's a group of patients? This shouldn't go. I guess I should have made that an answer. So you guys are very biomarker driven. Yeah. I think that's interesting. I'm interested to see as as we gather data in the US, how much is biomarker driven and how much is just empiric use of PARP in the front line. I think we're going to see a lot of biomarker selection, even though it's not necessary, but that's interesting. You guys are really biomarker driven, which I think is appropriate. You want to use the right drug for the right patient in the right setting, and biomarkers help you do that. So they're not perfect other than BRCA. HRD we need to work on, but it is what we have right now, and it's not bad. So we can use it. I think that's our last question, if I'm not incorrect. So we're going to move on to the panel, I believe. So I think we have a great panel tonight, and we're going to have opportunity to ask questions in Spanish, and I will answer them in English, and they will be translated back to you. So get your chat function ready to ask some questions, and we'll have some fun. Dr. Gallardo is going to help me. I think she's on mute.
Perdón. ¿Ya?
Now I can hear you. Yes.
Comentaba que en México estamos muy acostumbrados a hacer el estudio de la mutación germinal BRCA1 y BRCA2 por el apoyo que tenemos de la empresa farmacéutica que produce olaparib. Nuestra mayor experiencia en México es con olaparib. Con la información actual, sentimos que tenemos que migrar al estudio de la deficiencia de la recombinación homóloga, porque nos lo muestra el estudio de Paola y el estudio ahora de Prima. Sin embargo, no nos ayuda que la FDA haya aprobado el uso de un inhibidor PARP como niraparib sin requerir estudio de mutación ni de HRD. Y eso nos deja en indefensión, ya que sería una regresión si no hacemos estudio de deficiencia de recombinación y ni tampoco de estudio de mutación BRCA1, BRCA2. ¿Cuál es su recomendación? ¿Qué nos aconseja para México?
Yeah, I mean, I think that's a question that's come up when I've given similar talks virtually in different parts of Europe, where they, in Europe, they do not have coverage for homologous recombination deficiency tests. They're available, but patients would have to pay for them. So they're not used at all. And so they're very much in the same situation where These approvals are coming out, and we have all this biomarker data, but they can't utilize the biomarker data. So they're having to make decisions really just based on BRCA alone. I was talking to our colleagues in Egypt about this. They're using BRCA alone. They're making their decisions about whether or not to use, they don't have Paula yet. So it's really, if they know BRCA, they tend to be using olaparib. If they're not BRCA, they're offering patients niraparib without biomarker information. I do think that on one hand, I can argue it both ways. 50% of women with high-grade serous ovarian cancer have homologous recombination deficiency. So that's a lot. Of the 50% that either have homologous recombination proficiency, or some of those are just failed tests. So it's not 50% are HRP, like 35% are, and then there's 15% where the test doesn't work. So some of those are going to respond as well. So from a pragmatic standpoint, if I couldn't do any testing, then I would just have to talk to patients about the availability of this asset and kind of quote the intention to treat population, which combines it all. And I think that that's a fair way to counsel patients around the potential benefit of the drug, which is a hazard ratio of 0.63. So I don't think you're overselling something to a patient. We always have to be mindful about how we explain these concepts to patients. They don't understand hazard ratios very often, but it's a overall, in all comers, it's a clinically relevant but modest benefit. That's what it is. If you have biomarker data, you can really get much more granular with how much a patient in general could expect to benefit. So, I think in those settings, it really comes down to discussions with the patient and sort of what they're willing to tolerate from a toxicity standpoint versus sort of what about their biomarker status. And I think that's the best you can do. I have heard, though, that there are, and I don't know this, I don't know a ton of details, but I have heard statements made by several in the industry that the homologous recombination tests are going to be made available much more widely globally to countries that don't have them. So I do think that they will be coming to you to use. That is the indication that I have had from industry, and I think they're coming soon. So I don't think you're going to be operating in the dark for very long. But until then, I think you're going to have to just work with kind of what you have. And I would test everyone for BRCA as you're doing, and make sure all those patients get PARP, because you're going to cure some of them. I believe that. And then make the best decisions for the other 75% of your patients until you have kind of more biomarker data to work with. But it is frustrating. I don't have a great answer for you.
Y en México nos resistimos a tener una conducta regresiva, así que seguro lo vamos a discutir la comunidad de oncología para ir hacia adelante y además de hacer la mutación de BRCA, tener el estudio de HRD, de deficiencia de la recombinación, porque vemos que es algo sumamente valioso. Gracias, doctora.
I agree.
Moore.
Yeah, I agree. I think it's, I don't love the test. And I think the test could be much better. And there are many academic centers developing their own tests. So I think they're going to become very cheap and available and probably better. But you can't argue with, I showed you the data from Paula in the BRCA wild type HRD deficient group, which is the combination of PARP-Bev versus Bev, which are agents I like to use. And I would have thought that group might have been a little closer. I think I was a believer just that it was BRCA. That BRCA was driving the benefit from PARPs in all of these studies. But if you look at that group, the hazard ratio is 0.43 as compared to bevacizumab. So addition of PARP in that group is, I think transformative in terms of how well they do. And so I was not a believer. I was not going to send the test if I could use bevacizumab and PARP in everyone. But now that it's on label, and truthfully, now that I've seen the data with the lack of benefit for the combination of HRP, I really want to know that data because it may change how I treat patients. So I agree with you. I think the biomarkers, I would never go back. We have to test. Like, it would be unacceptable to stop germline testing, utterly unacceptable for families in terms of cascade testing, but also they are so informative in terms of how we select and sequence treatment options for our patients. So the lack of availability of these tests is really frustrating, and it's all a cost issue.
Claro.
Yeah.
Hay una pregunta del doctor Baena y dice lo siguiente. En población con mutación de BRCA, la proporción de riesgo en solo 1 y prima fueron de 0.30 y 0.40 de manera respectiva. ¿Usted cree que esta diferencia se deba a que olaparib es más efectivo que niraparib?
So that's a great question. And I know this is sponsored by AstraZeneca, but I don't think so. I think the difference is the different populations. So remember, the hazard ratio is a reflection of the reduction of the risk of the experimental arm to the control arm in that population. So in PRIMA, that population is an incredibly high risk population of BRCA-associated cancer. So anybody, but it was 70% neoadjuvant, 35% stage 4, very high risk. And so even in that high risk group, you saw this hazard ratio of 0.4 for BRCA. In PAOLA and SOLO, they're still high risk because it's all advanced stage, but they were much more stage 3s, primary cytoreduction. So they're just different populations. So I would not compare the hazard ratios and make judgment calls about one being better than the other. I really think that they're very similar in efficacy. They have differences in side effects, and so we can talk about differences there. But efficacy, I don't really think there's any data to suggest they're different. That's my personal opinion.
De acuerdo. Muchas gracias. Una pregunta más del doctor Baena dice, ¿cómo se podría explicar la eficacia de niraparib en tumores con recombinación homóloga proficiente, dado que el mecanismo de acción de los inhibidores de PARP se basa en el concepto de letalidad sintética?
Absolutely. You're absolutely right. I think there's probably many ways we can explain it. For me, I think that it's a failure of the test. And so if you remember, that test, that myriad test, includes loss of heterozygosity, telomeric allelic imbalance, and large state transitions. And each one of those three things contributes to a score that spans 0 to 100. And we picked 42 as the cut point. And so if you're 40, you're classified as homologous recombination proficient, but are you really? You're probably not. You're probably going to respond to a PARP. So some of it's misclassification because you picked one cut point and you said all these people are homologous recombination deficient and all these people are homologous recombination proficient. And some of them aren't. So there's likely to be patients in that group who are really 40 or 39, and they are going to respond to PARP less robustly than someone who's 60, score, but they're going to respond and you're going to see a benefit and a difference there. The other thing is that there's just a lot we don't understand. So for example, if you have patients whose tumors have deficiencies in like the ATR-ATM pathway, they can have DNA damage response deficiencies, but it's not homologous recombination. So they still may have synthetic lethality with a PARP in a different way, but they're going to show up as homologous recombination proficient. And so we don't pick those up. And then there's this whole other group of patients. There's a beautiful review paper by Pillay et al. It's Pillai et al. If you email me, I'll send it to you. It was in Nature Communication last year. It's beautiful. He has a great figure in there where he's got, you know, BRCA and then HRD and then this other group that's sort of BRCA like I just talked about. And then there's this group of, he calls PARPness, that are all of these changes that have nothing to do with homologous recombination, but do potentially make the tumor sensitive to PARP. Things like NAD positivity, Schlafen-11 is another one. That's important in pancreas. We don't really understand it in ovary, but Schlafen-11 may be important. Cadherin. So there's this whole other group of patients who may respond to PARP, and we wouldn't have predicted them to based on that HRD test, but it's because we just don't understand everything about how PARPs work. So I think that group is really interesting, and it's probably a lot of things, misclassification, and then also patients who benefit a little bit from PARP through these other mechanisms that are probably showing us that difference. But the difference is modest, you know, we have to say, and it's versus placebo in a very high risk population. So that's sort of my explanation for it. And I think as we start to study these patients more with homologous recombination proficiency by the Myriad test, we're going to really start to understand really who they are. And we don't yet.
Sí. Dentro de la audiencia se pregunta qué tan accesible es la prueba de Myriad en México, y bueno, es una pregunta que a lo mejor usted no nos puede contestar porque es algo que
I don't know the answer to that.
Que en México tendremos que resolver qué hacer, buscar las mejores opciones, lo más económico, la cobertura por los servicios de salud en nuestro país y la disposición de las empresas para migrar del estudio, de solamente el estudio germinal de las mutaciones al estudio en tejido de tanto de la mutación somática para BRAC como la de HRD. Ahorita no tenemos estandarizado en México el estudio del tejido. Eso es para la pregunta de la audiencia que se hace. Y voy a leer más. Esto lo hace la doctora Mónica Isabel Meneses respecto a Myriad. Y entonces, esa es la respuesta, doctora Moore, que yo le daría a la doctora Mónica Isabel, que iremos viendo en México, como usted ya nos dijo, qué podemos hacer mejor. Luego, hay una pregunta de la doctora Marina Quesada, que dice así: ¿qué esquema de tratamiento considera usted a una paciente con cáncer de ovario seroso papilar de alto grado que recibió cirugía inicial más quimio con carbo cada 21 días por 6 ciclos, con 3 años libres de enfermedad, actualmente con recaída y enfermedad residual de 2 centímetros? Ella no nos está dando el dato de que haya sido estudiada la prueba de la mutación. Al parecer esta paciente no tiene prueba de mutación, aunque bien en México lo que sí podemos decirle a Marina es que sí podemos hacer ahorita disponible el estudio de la mutación germinal BRCA1, BRCA2. Entonces, contéstenos por favor, doctora.
So she recurred after 3 years and has residual disease after a secondary surgery or after second chemo. I wasn't quite sure I followed what her treatment had been yet. What did she get? She got 3 years off, and then what happened at recurrence?
Luego la operaron, la cubrió,
Okay. Uh-huh.
y actualmente la doctora dice que parece ser que la volvieron a operar con citointroducción
Okay.
secundaria, porque dice que tiene enfermedad, ahora tiene enfermedad residual de 2 centímetros.
Okay. And how would I treat her if she's BRCA wild type? So honestly,
no lo dice.
So you don't know.
No lo dice.
That's, yeah. I mean, you have to, I think honestly you have to know, because it would change what I did if I'd get her started on chemo, you know, and I use in the second line, I like carboplatin and pegylated liposomal doxorubicin. That's sort of my favorite thing, but you can use whatever you want. And so I'd give cycle 1 and I'd send testing. If, you know, for residual disease like that, I tend to like to use bevacizumab, and bevacizumab has an overall survival advantage, but I'd want her tested. So if she were a BRCA associated cancer, I would certainly not start bevacizumab because it's not indicated. The combination's not indicated in the recurrent setting, even though I would love to get away with using it at, you know, it's just not indicated. So I wouldn't start it, and I'd wait to use a PARP, you know, in the recurrent setting as a switch maintenance once she has responded. So at the very minimum, I'd want to know BRCA status. So I think you have to send that. You know, and I'd also want to send her tumor from her second surgery and see if she was homologous recombination deficient, because those two things might make me wait and use a PARP for maintenance. You don't need to be biomarker positive in the recurrent setting. You know, anyone can use it because they do see benefit in even homologous recombination proficient, again, in that population. But certainly if I knew she was BRCA and if I knew she was HRD, I'd probably hold off on the Bev and just wait to use PARP. Otherwise, I'd probably use bevacizumab. But that's just me.
Por supuesto. Muchas gracias. Luego, la doctora Meneses, Mónica Isabel Meneses, dice, ¿qué porcentaje de pacientes tienen deficiencia en la recombinación homóloga? Creo que en la presentación de usted.
So it's in frontline, it's 50%. And then of that 50%, about half is BRCA, either germline or somatic, or other BRCA changes like promoter methylation. And then the rest are BRCA wild type, and for other reasons have homologous recombination deficiency. So 50%.
De acuerdo. Muchas gracias. Otra pregunta más de la doctora, esta pregunta es de la doctora Lorena Lechuga, y dice, parece no haber diferencia entre niraparib y olaparib, refiriéndose a la eficacia. ¿Cómo es que usted escoge cuál usar?
Yeah. So I tell you, I do, they are, I think, very similar in terms of efficacy. They do have different side effects. And I use both. I'm going to be honest. I use both in different patients for different reasons. So just to, and again, I know this is sponsored by AstraZeneca, but I would say this anyway. Olaparib for me is the easiest one to use because the hematologic side effects of the 3 PARPs that are available, rucaparib, niraparib, and olaparib, olaparib's hematologic toxicities are the least severe. So, you know, you only have about a 6% risk of grade 3 or higher platelets or grade 3 or higher neutrophils. The anemia is a little bit less than niraparib. It's only about 21% of women will have grade 3 or higher anemia. So I find that the hematologic side effect profile is really very manageable. And I like that aspect of olaparib because I don't have to be as worried about someone's platelets really dropping. With niraparib, with the individualized dosing, where you start it based on the patient's weight and baseline platelets, the risk of very severe thrombocytopenia has gotten much better. You know, it was 30% when it was flat dosing of 300, and now it's down to 13%. So it's definitely much better and a much safer way to dose, but it's still 13%. So for me, if I have patients who, especially in the recurrent setting, if I was sort of struggling to get them through carboplatin and there were lots of holds for platelets, you know, I'm going to always sort of edge towards olaparib just because I think it's less bone marrow toxic. But, you know, I have patients that I take care of who, from the very beginning, tell me how terrible they are at taking oral medications, and they're not lying. You know, you have these patients that are like, I can't swallow pills. You know, they know the pill size that they can swallow, and anything above that they can't swallow. It's not a small number of patients. They really struggle with oral medications. And so for them, niraparib is a nice choice if I really want to try a PARP. It's only once a day. And they can take it at night, and I can pre-medicate them with an anti-nausea medicine, and they can kind of sleep through the side effects and wake up and not have to take it in the morning. And so it reduces the pill burden a little bit for them, as opposed to taking something twice a day. So I think that's a nice option. So I kind of look at the individual patient but I use both of those agents. I and my office is very comfortable. Taking care
en
of.
México, perdón. Gracias, doctora Moore. En México, nuestra experiencia con olaparib la empezamos a tener con pacientes multitratadas que habían recibido hasta 4 líneas de quimio previa. Y tuvimos pacientes con mucha anemia.
Oh, yeah.
Con mucha anemia. Grado 3,
Yeah.
4. Hicimos
Definitely.
La doctora Gaby Alamilla.
I think that's true. But we use it so much earlier now. You know, I think you're right. The early days of PARP was in very late line therapy, and they're so beat up that anemia really is an issue. I think it's still something, it's 21%, you know, in the front line. So it's not zero. You do have to pay attention to it, but I think it's much better the earlier you use it.
Así es. En esas pacientes le queremos comentar que una iniciativa de la doctora Gaby Alamilla fue hacer un ajuste de dosis al 50% de olaparib. Y lo comentamos con el doctor Lederman en aquella ocasión. Y nos fue bien con ese ajuste de dosis. Ahora no hemos tenido ese problema porque, como usted bien lo dice, usamos el olaparib de manera más temprana. El doctor César González de León pregunta, doctora, si su paciente no hubiera estado mutada, ¿le daría niraparib en vez de bevacizumab?
In the recurrent setting? In what setting?
En el caso clínico que usted nos puso.
Oh, in the clinical case, in my case, if she'd not had a BRCA, okay. Well, that's a great question, because I'd already started bevacizumab. So what I would have done then is I would have tested her for HRD. Now, then I wouldn't have had that. So in 2017, I didn't have that. But now if she was BRCA wild type, I would test her for HRD. And if she were homologous recombination deficient, I would put her on a Paola type regimen because I had started bevacizumab. If I hadn't started bevacizumab, then I still would do the testing, and then my option for BRCA wild type would have been niraparib. And I like niraparib. I would use it. You know, I would counsel patients about it. So I can't guarantee you I would have used it, but I would have talked to the patient about it. Absolutely. I wish there were a monotherapy olaparib indication too, but you know, that's my only option for monotherapy BRCA wild type right now.
Gracias. El mismo doctor César González de León pregunta lo siguiente, dice, doctora Moore, ¿no le parece escandaloso, escandalosamente inadecuado que Paola no tuviera un brazo con PARP inhibido solo? Usted me comentaba,
Yeah.
usted comentaba.
It's tough though, because you got to think about that. So number one, let me just tell you, Paola was an investigator-initiated trial that Isabella Ray Cucard got AstraZeneca to fund. So it was never designed as a registration trial. So you have to know that. So the fact that she ran this beautifully done study, investigator-initiated, and still got a registration out of it is pretty amazing. I don't know if people really know that backstory. It was not designed as a registration study, number one. Number two, it's really hard to do that. We struggle with that because you would have to stop the bevacizumab or somehow randomize patients to either getting bevacizumab with chemo or not, and then randomize them to PARP. It would be a huge study. But we run into this as we try to design even platinum-sensitive studies now where we want to have bevacizumab in one arm but not in the other arm. And it's just very difficult to have these sort of unequal treatment arms, and to have an arm where someone got bevacizumab with chemo and then say, okay, now you stop it, and I'm just going to give you monotherapy PARP, may be okay, but you're not using bevacizumab in the way it's shown benefit, which is in the maintenance setting. So it's a very difficult thing to sell. I'm going to tell you, we really struggle with that when we design clinical trials, inclusive of bevacizumab, to stop the bevacizumab and switch to something else. It's really been one of those things that we argue about a lot. So, do I think it's sad that there's a missing arm in Paola? Yes. I don't quite know how they would have designed it without making it a really huge, almost like a 2x2 kind of factorial where you randomize to bevacizumab and then randomize to the PARP. It would have been a gigantic study. Maybe they wish they'd done that now. But as it was, Dr. Ray Cucard did an amazing job taking a personally driven study all the way to registration. So I'm really proud of her. And it got us a great new option for our patients, just not all the ones we would want. Yeah.
Claro. Por otro lado, nos llama mucho la atención el dato que usted presentó con un mejor resultado en BRCA2 que en BRCA1 mutado. En México.
Yeah, you know, Prima showed the same data and they look about the same, but again, that's a high-risk population. I think we have to just watch that a little bit more. I'm interested in that. I don't know that it changes right now what I would do. You know, some day in the distant future, maybe we could de-escalate therapy for those women. You know, maybe they're cured with 1 year instead of 2 years, but don't do that. Don't do that. So I think it's interesting. It makes me happy when I have BRCA2 on the genetics report because I feel like the patient's going to do really well, but I'm still going to be uber aggressive in trying to do all the things to help her live as long as possible. So I think it's really interesting. It doesn't really change my actions yet, but someday it might. Once we've gathered enough information, they may not need as much therapy.
La proporción de BRCA2 en nuestra población y seguramente En el resto del mundo es la menor proporción de población mutada. La más común es BRCA1, de población con
Yeah.
mutación BRCA1. En México
Yeah,
tenemos una mutación
right.
en...
It's about 20%.
Sí.
Yeah, about 20%. So
Y-
small numbers, but the more of these studies we do, and now we're testing everybody, we'll actually have enough of them eventually to really make some statements about kind of how best to treat them. Kind of the same thing with, for example, RAD51C, which is 1 to 2%, right? But we're finally testing enough that we've gathered a big enough pool to know that that's a predictive biomarker for PARP as well. So I think as we're doing these studies and now testing is just required in every study, we're actually going to understand eventually a lot more about these very uncommon and rare mutations and be able to counsel our patients better, and know if the mutations differ regionally. Does Mexico have more RAD51C? Does China have more? I mean, it's just, we just don't know this data yet, so we're collecting it. Certainly the variants differ. The variants of uncertain significance differ country to country. So classifying them really depends on testing.
Justo a ese respecto, en México, en BRCA1, tenemos la mutación de un gen fundador dada por la deleción del exón 912. Y un dato interesante es que 8 de 37 mujeres tratadas con olaparib que tienen ese gen fundador en BRCA1, solo una ha progresado a 19 meses. Entonces, estamos muy motivados a estudiar qué pasa de manera comparativa, prospectiva, cuando está el gen fundador en BRCA1 contra el BRCA1 sin el gen fundador, porque estamos encontrando que con el gen fundador tienen supervivencias libres de progresión sostenidas, más largas, que cuando no lo tiene el gen fundador. Entonces, ese dato se nos ha hecho muy interesante. Hay una pregunta del doctor José Luis Rodríguez Olivares que dice: considero que identificar otras mutaciones germinales en genes como PALB2, CHEK2, ATM podría tener un impacto positivo en elegir olaparib de mantenimiento.
Yeah, I mean, we're collecting all of that. There's a lot of work being done, in a lot of these studies, even though we say we looked at BRCA1 and 2, these big panels were run to try and look at these other mutations that we're finding and see if they are predictive for response to whatever, a PARP or whatever we're testing. So I can't say that anything else just yet has risen to the top like RAD51C, where there's finally enough data, but any of those, are candidates. We just need more data, and it's coming. But I agree. But you need the data, otherwise you're guessing. You're just like, oh, I'm going to use a PARP and check 2. Well, you don't know that check 2 means anything for response to PARP. I mean, I understand why you'd want to do it, but we need to prove it or disprove it, so that we can be informed.
Por supuesto. Una última pregunta. La doctora Araceli Mireya Peralta. Ella cuestiona el tema de anticonceptivos hormonales como factor de riesgo en cáncer de ovario. Y junto con esto le quiero yo preguntar, el tema de receptores hormonales estrogénicos en cáncer de ovario ha sido poco estudiado. ¿Esto podría ser un blanco terapéutico?
So I think I missed the question. So the question was hormone hormone.
Anticonceptivos orales. Ah, perdón. Los anticonceptivos hormonales. Más bien es terapia de reemplazo hormonal, sería. Terapia de reemplazo hormonal.
Hormone replacement therapy.
Sí, y riesgo para cáncer de ovario. Y paralelo a esto, la utilidad
Okay.
de receptores estrogénicos.
Yeah, there's actually, gosh, I should be able to find it pretty easy. So there's actually a recent paper out about use of, I was going to try and find it, hormone replacement therapy in women with ovarian cancer and other gynecologic cancers. We really think that low dose estrogen, and certainly if they have a uterus, they need progestins as well, is okay. So we really don't think that it is associated with development of at least high-grade serous or high-grade endometrioid ovarian cancer. And we don't see any association with poor prognoses for women who really would benefit from it from a quality of life standpoint. So, we were just talking about this on a different kind of Facebook page, and we had the citation up, so it's just really fresh in my mind. That it really is okay to use. Now, that being said, we tend to try non-hormonal things first, just to avoid any of the other risks, such as, increased risk of blood clots, for example. That is a concern. And some of our patients are smokers in the US, and so it's just not safe for those reasons to use hormonal therapy, because we don't want them to get blood clots. So for us, the use is probably pretty low because of those other issues, but not because we're worried about negatively impacting our patient's outcome. Now, for women, just the caveat to that is for women with low-grade serous ovarian cancer, which is hormonally driven, we don't think it's caused by exogenous hormones, but without data, but people that really live in the low-grade tumor space, like Dr. Gershenson, will say that he does not use hormone replacement in those particular cases. So I just wanted to be really specific. I'm not talking about all ovary cancer, but high-grade serous, high-grade endometrioid, really we have data that it's safe. Low-grade serous, low-grade endometrioid, those have lots of estrogen receptors, and we use letrozole and all the SERMs and SERDs and those as treatment. And it works in low grade, and so you wouldn't want to feed the tumor with hormone replacement. So you do have to distinguish high and low grade carefully there.
Sí, más bien es, por un lado, que la terapia de reemplazo hormonal es un factor de riesgo, fuera un factor de riesgo para el cáncer de ovario, y por el otro es si el uso de antiestrógenos es útil como coadyuvante en el tratamiento. ¿Cuál es su opinión?
I don't think it's a risk factor. I don't think use of hormones is a risk factor for development of ovary cancer. And then in high grade ovarian cancer, there's a little data for anti-estrogens, like as a maintenance. There was a really small study out of either Memorial Sloan Kettering or I think it was Memorial a few years back that suggested a little bit of benefit, but it's pretty modest. So I don't really think in high grade we've shown tremendous efficacy with that class of agents like we have in low grade. So I do use every once in a while, I'll try Femara, in patients who have bone marrow failure. I'll try to treat their ovary cancer with Femara or letrozole. It does not work very often. So it would not be my go-to regimen, in the setting of other good options for somebody. Yeah.
Muchas gracias, doctora Moore. Son todas las... Creo que ha sido súper provechoso y que tenemos ahora una idea mucho más clara de lo que tenemos que hacer y hasta dónde podemos llegar con las terapias de mantenimiento. Muchas gracias.
You're so welcome. Happy to be here.
A nosotros también, muchísimo. Y muchísimas gracias a toda la audiencia que nos ha acompañado esta noche. Gracias a todos.